Patients with acromegaly already complain of cognitive deficits, and the cognitive deficits in patients that have undergone radiotherapy are much higher. So there's a very negative effect on quality of life in acromegaly. There's also an increased mortality after pituitary radiotherapy, and this is caused by cerebrovascular mortality. So Ariel Barkan, who's very well known for his statements, says that in modern time, that radiotherapy should not be given anymore on a routine basis. It's a treatment of last resort. So what about medical therapy? I think the spectrum has changed a little in this aspect. It's now considered first-line therapy when there's a low probability of a surgical cure, or when surgery has failed to achieve biochemical control. Some give it prior to surgery to improve severe restrictive comorbidities, or issues that should complicate surgery. But the duration of the treatment, nobody knows. It should be individually determined. There's also a lack of evidence that pre-surgical therapy can improve perioperative morbidity. So what drugs are available? And I think here the main problem is availability and price. So we have the dopamine receptor agonists, and especially carbergoline is now in the picture. We have the somatostatin analogs, and we have the growth hormone receptor blockers. So with regard to carbergoline, this study by Roger Abs from Belgium shows that in patients with acromegaly, a dose with a maximum of 3.5 milligrams per week, so that's much higher than we generally need for prolactinoma patients, is able to reduce the elevated serum IGF-1 levels into the normal range in blue in about 40% of patients, and especially the patients with the lower baseline IGF-1s are the best responders. So normalization of IGF-1 in about 40% of patients. In the past, we were learned that co-secretion of prolactin or hyperprolactinemia in an acromegalic patient makes them especially a good candidate for dopamine agonist therapy. And most think that's not true anymore. As shown in the slide, it's more effective in patients with modest elevations of IGF-1, and we can combine it with other therapies like somatostatin analogs. The side effects are nausea, constipation, orthostasis, mood disturbances, headaches, and then there's this heart valve issue that was more prevalent in patients with Parkinson's disease being treated with much higher dosages of carbergoline. And in fact, most agree that heart valve disease is not prevalent in patients with acromegaly with the doses we use now. This is an interesting picture. This is Leonard Mark. It's an old book. And this is a patient and a physician. And he describes his own life story of acromegaly. You can buy the book in antiquarian shop. So this is him age 25 and this is him age 56. And he's a physician describing everything that happens to you when you develop acromegaly and how long it took to diagnose his disease. So this is a rather busy slide on somatostatin analogs. But the only thing I want to show you is that the efficacy varies according to the studies, with a low efficacy in this study being IGF-1 normalization with somatostatin analog in 38% of patients, and a high efficacy of about 75% in another series. So IGF-1 normalization occurs into up to 67% of patients. Control of growth hormone secretion in about 57% of subjects. In about 1/3 of patients there is a 1/4 to half shrinkage of the tumor size, and another 18% of patients show a 10 to 25% tumor shrinkage. Side effects are gallstones, mostly asymptomatic. GI side effects usually resolve, and then more severe side effects like bradycardia and impaired glucose tolerance. So, upper left panel shows the naturally occurring somatostatin 14. And here you see octreotide, which is derived from it. And here's a new kid on the block, pasireotide. The thing is that the currently available somatostatin analogs have a high affinity to the subtype 2 somatostatin receptor. And whereas naturally occurring somatostatin has an affinity to all receptor subtypes, these compounds have a good affinity to the subtype 2 and a low affinity to the 3 and 5 subtype. This new drug, pasireotide, has an affinity for all receptor subtypes except the 4 subtype. And there's another new drug in development. This is a BIM compound, which has a good affinity to the 2 receptor and to the 5 receptor, and, not shown in this picture, has a dopamine D2 receptor affinity. So, first of all, somatostatin binds to all 5 subtype receptors. Octreotide and lanreotide only bind to subtype receptors 2, 3 and 5. Pasireotide binds to all receptors, subtypes, except the 4 subtype. And the BIM compound binds to 2, 5 and the D2 receptor. So in our lab, we study pituitary adenomas from patients with acromegaly. And here you see 7 pituitary adenomas, and you see their receptor profiling. And you see that most tumors express SST2 receptor subtype in, well, varying amounts. Some express the subtype 3 receptor, and the majority also expresses the SST5 receptor subtype. So I've shown you 2 drugs. One drug with affinity to 2 and a little bit 3 and 5, and the other drug, pasireotide, with affinity to 1, 2, 3 and 5. So this is a patient with acromegaly. In black is his baseline growth hormone levels, which are elevated as you see. And then in red you see the pattern after the injection of 100 micrograms of octreotide, and you see a very nice suppression of growth hormone levels over the time. And this effect wanes after, let's say, 12 hours. And a similar pattern is shown with the new drug pasireotide in blue. This patient was operated, and also in vitro there was a good effect with regard to growth hormone suppression by octreotide and pasireotide. And the receptor profiling showed that there was a good expression of the somatostatin receptor 2 subtype, but also of the 5 subtype. So no difference between the 2 drugs. This is another patient. Again in black, his baseline growth hormone levels. Then in red, the growth hormone levels after octreotide, and you see that there's hardly any difference between the baseline and octreotide levels. On the other hand, after pasireotide, there's a very good growth hormone suppression, like in the previous patient. In vitro, octreotide wasn't very efficient in suppressing growth hormone, and you can see why this is the case, because this patient has a low expression of the 2 subtype and a good expression of the 5 subtype, and the affinity of pasireotide for the 5 subtype is much, much higher than of octreotide. So this means that some patients that are resistant to somatostatin analogs that are currently available might benefit from pasireotide. Well, this has been studied in an international study, and this has been published by Stefan Petersen, and this is a study where patients were first treated with octreotide and then switched to pasireotide, and on the basis of IgM1 levels they were switched to higher or lower dosages of pasireotide. And here you see the results of the studies. So in the left white panel you see the octreotide results, meaning normalization of IGF-1 and or suppression of growth hormone. In blue, you see the light blue, you see the lowest dose of pasireotide, dark blue the higher dose, and in red you see the highest dose of pasi. And you see that in this study there was a superior effect of pasireotide in their patients. And with regard to tumor volume, there was a reduction, as shown in the left, in most patients. One thing to worry about is blood glucose levels. What's done here is they have divided the patients into groups according to blood glucose levels at baseline, and then have looked at the post-treatment levels. And you see that patients that were in the low group moved to a higher group, and also here these patients were in the 5.6 to 7.7 millimolar group, moved to this higher group. So in fact there was an increase in blood glucose levels in about 20 to 50% of patients. So, good biochemical cure, reduction in tumor volume, well tolerated, GI side effects, but be aware of glycemic changes. And they say this is consistent with those observed with all the somatostatin analogs, but some of us don't agree with the statement. Another expensive drug is a drug called Somavert or pegvisomant. This drug interacts with growth hormone receptor dimerization and acts as a growth hormone receptor antagonist. So it blocks the growth hormone effects. Growth hormone is still high, but it cannot do its work because the receptor is saturized by this drug. Very efficient drug, as shown in this initial study by A.J. van der Lely, shown that daily dosing causes, in doses up to 20 milligrams per day, a 90% control of IGF-1 levels. Growth hormone levels are of no use because the growth hormone is not blocked, so it will be high. It even increases in some patients. Tumor volume changes. People were very worried about that. It's not a big problem. It only occurred in 2 patients that were not treated with radiotherapy. So, normalization of IGF-1, mean dose used 70.4 milligrams, improved glucose control, increased tumor growth, less than 5%. What should be worrying is sometimes there are abnormal liver function tests which resolve after discontinuation, and there can be local lipohypertrophy. So what we did then is we started combinations of somatostatin analogs and pegvisomant. The reason was we wanted to be cheaper, because as you see we used weekly dosing, and we wanted to be more efficacious. So here you see 32 patients with non-controlled acromegaly using somatostatin analog, and then in the blue dots you see the response in the individual patient when pegvisomant was added, and you see that the majority of patients are very well controlled. Of interest is also the quality of life issue. So what Sebastian Neggers did was he switched patients from pegvisomant to placebo or from placebo to pegvisomant with a 4 weeks washout, and he looked at quality of life issues. And here's the quality of life. So if you start with pegvisomant, your quality of life increases. Then if you switch to placebo, it goes down again. And here's the opposite. If you start with placebo, you have this quality of life, and it increases after pegvisomant. Either total or physical quality of life. This was accompanied by a weight loss of about 0 to 4 kilograms, mainly water content. What's of interest is that there's a very nice review now out in European Journal of Endocrinology, where the authors try to explain that by using terminology like systemic acromegaly. What we have done in the past is controlling IGF-1, so we control the growth hormone state of the liver, but it might be the case that other organs see the growth hormone effect still and have problems with that. With combination therapy, you block the IGF-1 production in the liver, but you also block the local effects of growth hormone on the several tissues. And maybe we have a better tailored therapy with a combination therapy than with a monotherapy. Just an illustration that elevated liver enzymes occur more frequent in the combination therapy, and you see that it is dependent on pegvisomant continuation, as shown here. When you stop the drug, the elevated liver enzymes go down. So, combination therapy is as effective as monotherapy, but cheaper because you need a lower cumulative dose. You have to be aware of elevated liver enzymes. These occur in combination therapy more often than in monotherapy. Patients with diabetes mellitus seem to be a higher risk, and you can reintroduce it by re-expose it. There is a decrease of tumor size, and we didn't observe any increase of tumor size. And there are favorable effects on quality of life. So, this is my final slide, showing one of the graphs from recent consensus papers. And what has changed, in my opinion, is that surgery has still a central role, but only for micro or intracellular macroadenomas. And if surgery is contraindicated or there is a low expected cure rate, like in patients with paracellular invasion, they recommend medical therapy. You see all the different therapies. And if your IGF-1 stays increased, you have to consider alternative therapies, but I've shown you that this is hardly the case. So I want to stop here and thank you for your attention.